Greetings and welcome to EHA Unplugged, the official podcast channel of the European Hematology Association EHA. My name is Isabel Olivera and I'm a medical writer for the EHA. I have the pleasure to have here with me today Professor Stefano Luminari. Welcome, Professor Luminari. Can you please introduce yourself?
Hi everybody, I'm Stefano Luminari. I'm a professor of medical oncology, actually a hematologist by training, and I currently work in the University of Modena, Reggio, Emilia in Italy. My main field of interest and research are lymphoma, and in particular indolent lymphoma and follicular lymphoma specifically.
Thank you. So we are going to discuss today the current precision medicine approaches to the diagnosis and treatment of follicular lymphoma. To start off, can you please explain briefly what follicular lymphoma is?
Sure. Follicular lymphoma is a lymphoma deriving from B cells and is the most frequent and actually is the prototype of indolent lymphomas. And as all the indolent lymphomas, it typically affects the old population, even if the median age is a little bit younger than compared to other indolent lymphomas. The disease is typically indolent at onset, and the expected survival for every patient that is diagnosed with follicular lymphoma is excellent. And nowadays, the median survival is measured in decades. Even if it is not considered a curable disease, an actual cure can be achieved in approximately 20-30% of the patient with current available therapies. And overall, the impact of the disease and diagnosis on the life expectancy is very low, with few exceptions that are represented by patients who relapse early, starting from initial therapy, or patients who have multiple relapses.
So, our biological understanding of the molecular events that are underlying follicular lymphoma cells has improved a lot lately. Can you give us an overview of which molecular events are the main causes of follicular lymphoma?
From the biological point of view, follicular lymphoma has been considered an easy lymphoma because in approximately 95 or overall 100% of the patient, there is a typical chromosomal translocation. There is a T14/18 translocation that puts the BCL2 anti-apoptotic gene under the control of the promoter of the immunoglobulin genes in chromosome 14. The chromosomal abnormality can be detected very easily by FISH, by PCR, and it's being considered a hallmark of the disease. Actually, it is, however, more important from the diagnostic point of view rather than from the pathogenic point of view, because the presence of the T14/18 translocation is required, but is not enough to grant transformation. There are additional genetic events that are required to move a B lymphocyte from normal aspect to the pathologic aspect of follicular lymphoma that are most of them are now known and mostly include alteration in the epigenetic machinery and in the cell cycle regulation. The most frequently altered gene that adds to the 14/18 chromosomal translocation are CREBP, EZH2, KMT2, and in addition, there are genes that are involved in the cell proliferation that are not only considering p53, but p53 is most frequently altered, but other genes can mutate and to add aggressiveness to the disease.
So the detection of these different mutations is being used for a better diagnosis, a more precise diagnosis of follicular lymphoma and to tailor the treatment?
Unfortunately not. Better to say not yet. There are few attempts to move these genetic alterations from the simple and the easy definition of the pathogenesis and the diagnosis to a drive a therapeutic approach. But there is only one example among the several mutations that are known, that is mutation of the EZH2 gene, that can be targeted with a drug that is now available, mainly in US, approved by FDA, that is tazemetostat, that is inhibitor of EZH2. Apart from this, the genetic alterations that are known are variously used to define prognosis and prognostic aspects of the disease, but not used to drive any treatment decision. And in discussing about this, the most important example of how this mutation can be moved to the a precision approach to follicular lymphoma is represented by the M7 FLIPI, which is a prognostic index that puts together the clinical aspect of the disease defined by the FLIPI prognostic score with mutation of some of the most important genes in terms of those that have prognostic role. There are actually 7 genes that are added to the clinical features to better define the prognosis of patient. And this M7 FLIPI have been validated in a series of patients from US and has been shown to better discriminate the prognosis and in particular to better identify patients with aggressive features with high-risk disease.
So even if this is not been, this molecular characteristics of the follicular lymphoma cells has not been used for the diagnosis, there have been many novel therapies for follicular lymphoma discovered lately. Can you give us an overview of these targeted therapies and their justification?
Among the targeted therapies that are now available and that are now providing very exciting results in the treatment of follicular lymphoma, very few of them are actually addressed to the molecular features of the disease. And actually, as stated before, there is only one drug that targets a mutation, that is tazemetostat against AZH2 mutated cases. Most of the novel approaches to follicular lymphoma are actually agnostic of the mutational landscape of the disease because they're mostly developed targeting the surface of the B cell, starting from rituximab, anti-CD20 monoclonal antibody. Most of the new agents, referring in particular to bispecific antibodies and to CAR-T therapies, are again addressed to targets on the surface of the B cells that have little to do with the mutation complexity of the cells in the nuclear part, in the inner part of the cells, but are more common to all the disease. And the successful the success in the clinical results achieved with these agents is probably actually due to the fact that we are not taking too much care of what happens inside the cells, because targeting the outside layer of the cell is enough to kill the lymphoma and to achieve these exceptional results.
So the current NCCN and ESMO guidelines list different options for first-line therapy as well as for second and third-line therapy. So among these multiple treatment strategies, how to choose the right treatment for the right patient at the right time?
Yeah, this is an interesting question in a podcast that discusses about precision, because I would call unprecision approach to follicular lymphoma. Actually, the current guidelines, the available guidelines, are very high level in the definition of how to manage a patient. Patient with follicular lymphoma should actually be managed according to the stage of the disease and to the quantity of the disease. That is concept that is now defined as tumor burden. There are basically two main rules. One is treat with the local treatment patient with localized disease, so stage 1 or 2, regardless of the biology. And local treatment in this case means radiotherapy, which can be used with standard dose of 24 grays to achieve not only a good control of the disease, but also a cure of the patient that with current available data is supposed and is projected to be around 75% of the patient. So 75% of the patient with stage 1 can be cured by lymphoma only with local therapy if the disease is stage 1. For the advanced stage patient, it means stage 3 and 4, the other rule is to only treat a patient if the disease becomes symptomatic, or the disease appears with a tumor burden, high tumor burden status. That means it's not the quantity of the disease measured by stage, but it's the disease that causes symptoms that requires systemic treatment. And according to the guidelines, we are still based on the use of conventional approaches, mainly immunochemotherapy, in this case, if a patient has advanced stage symptomatic disease, all the guidelines are agree to suggest the use of systemic immunochemotherapy to have the best control of the disease and to achieve the best results that we now have with our patient. And immunochemotherapy actually means a combination of anti-CD20 monoclonal antibodies, rituximab or obinutuzumab, with a chemotherapy backbone, which is basically a choice of CHOP, bendamustine, or CVP.
So we are not ready yet to get rid of chemotherapy for these patients.
You're right, saying not yet, but I think that based on what we see in the later lines of therapy, in a phase in a patient population in which we have excellent results with novel therapies, we are expecting significant and important changes in the next future. And I would say the future is already here because we have novel options already available for the treatment now of multiple relapsed patients. So from third line onwards, so from second relapse onwards, we now have access to some of the most exciting therapeutic options that are available, mainly referring to the so-called T-cell engager therapies, which include bispecific antibodies and CAR-T.
So these bispecific antibodies and CAR-T cells are being used only in third line or second line?
So the bispecific and CAR-T are actually registered and reimbursed from third line onwards, based on the results of the pivotal studies. However, the clinical research is moving very fast, and we are now accumulating the first clinical research data for the second line, and there are a huge number of clinical trials that are now moving, in particular bispecific antibody, to the first line treatment. And we'll see, we have to wait some years to see the results and to see if they actually can change the whole approach to follicular lymphoma, which I expected to be chemo-free in a short period of time. Already now, with the option that we have in the second line or in the relapsed refractory setting, I see chemotherapy, the role of chemotherapy, being significantly reduced. We now have, apart from T-cell engager therapies, we have other chemo-free options that have been associated with excellent results. I'm mainly referring to the use of immunomodulatory agents, mainly referring to lenalidomide. With the R-square regimen, that is rituximab and lenalidomide, we have an important option for the relapsed refractory setting that is not only easy to use, but has a very manageable toxicity profile and a very good efficacy profile that represent now the mainstay of the treatment for the relapsed refractory patient. And that adds, in a future view, without considering too many years to get there, a significant change in the approach. So I think that now we can say that chemo-free is there for follicular lymphoma for the relapsed refractory setting, and we should be substituting, I believe, chemotherapy in the first line setting with the results of the currently ongoing clinical trials.
So this is in the near future, hopefully. What else does the future hold for you? What do you find most promising in what is being developed at the moment?
For sure, the new drugs are always very important opportunities. I referred to T-cell engagers, bispecific, CAR-T, there are the IMiDs, there are the novel generation IMiDs, and there is a novel interest in BTK inhibitors with the results of the zanubrutinib study in combination with obinutuzumab. There are a lot of new agents that luckily and after many years of lack of novelty are significantly changing the way we see the future of follicular lymphoma. However, I would like to remind all who are listening that now with the current available approaches, follicular lymphoma survival is measured in decades. That means that the impact, as I stated before, of follicular lymphoma diagnosis is very limited on the life expectancy. So, and this is what we want to give to our patients. So we are already there. And with the novelty that we have introduced with probably more effective therapies, we should be very careful to identify the right place of the right drug for the right patient in order not only to achieve the good clinical results. We are already there with clinical results, but to treat the patient without causing any significant problems in the post-treatment phase. That is the way I see the current challenges for follicular lymphoma management. With chemotherapy, we know which are the risks in the long-term outcome of this patient. There is second cancer, immunodepression, a significant risk of infections. So we should look at these features, these endpoints and outcome measure to really understand and to really define how we are going to improve the management of our follicular lymphoma patient. I don't think that we are able to improve survival more than we are now doing with conventional therapies. Well, we're changing the paradigm of therapy, but changing the paradigm of therapy, we should look more to the quality of life in general and to the risk and the occurrence of late events rather than trying to prolong something that we already achieved and prolonged enough to grant the patient what we are now seeing with offering with the current available therapies in follicular lymphomas.
Would it be a goal to cure the patients in a short time with few therapies so that there are less side effects or nocive effects for the future?
Yes, I think the curability of follicular lymphoma is the challenge. And I think that this question about curability is what we expect from these novel approaches of immunotherapy agents that are used in follicular lymphoma. I believe that what we should ask to these agents is whether it is possible with an early use of these agents to actually eradicate the disease and to change the paradigms that we are now considering for follicular lymphoma of an incurable disease. So even if the disease may not relapse now in a patient treated with immunochemotherapy, the risk of relapse is already there, is always there, and we are not able to say to the patient, you are cured. With this agent, we should understand if it is possible to say, I'm going to give you a treatment that is not only safe, but is able to eradicate the disease and to cure you without any significant late effects in the future. I think this is precision medicine today in the management of follicular lymphoma and hopefully in other indolent lymphomas.
So is there anything else you would like to add for our audience as a takeaway message?
Sure. So a lot of things are changing in the way we are going to treat and to manage our patient with follicular lymphoma patient. And my most important take-home message is to carefully look at the data we are going to see in the future, not only limiting to observing the number of complete responses that we see, that is important, and to the duration of response, to the progression-free survival, but also to look at additional outcome measures that I believe should become more important than only activity of the drug that include and are not limited to quality of life of the patient, to the occurrence of late effects, to the manageability of eventual relapse after this novel agent. We know very little about that now because the follow-up of the studies with these agents is very short, is still very short. We need time to really understand if we are doing the best possible for our patient or not. But I would say I have a very positive view of the future.
Thank you for this very enlightening discussion. Thank you, Professor Luminari, for sharing your expertise with us, and to all of you for listening.